Good morning, everyone. I do want to start by saying that the presentation that just finished, I can't encourage you enough to take the time to go back and read those slides in depth. There's a tremendous amount of information there that really does put our work in collecting this data in context. So I would urge you to go back and take an in-depth look at it. So my job this morning, aside from making sure that you're all wide awake and ready to go, is to give you an overview of the Oasis changes from C2 to Oasis D. In this presentation, and in all of the work we do over the next 2 days, we'll be using these different abbreviations. And in view of our time crunching, I'm going to just say to you that there are 4 pages of them, and you should know these by now, so we're not going to spend time looking at them. Our goal over the next 2 days is to really be familiar with the changes. Today, my piece of this is to lay the groundwork by summarizing an overview of the changes. We talked about this for those of you who are on the presentation August 28th, and what I'm giving you is a summary of that. Hopefully, by the end of my short time with you, you will be able to discuss the Impact Act itself, identify the relationship between the data that you're collecting on the Oasis tool and the Impact Act, and why that's important. You should be able to discuss the changes from Oasis C2 to Oasis D. The Impact Act itself, if you recall, was signed into law 10/6/2014. Its purpose was to require all of us in post-acute care to report standardized patient assessment data and quality measure data, so that finally, all of us in the post-acute care world would actually speak the same language. In the post-acute world, it's long-term care hospitals, inpatient rehab facilities, home health agencies, nursing homes. We are what comes after the hospital, and we have not been speaking the same language for years. The driving force behind the Impact Act was to improve beneficiary outcomes, to provide access to data that will facilitate our ability to coordinate care. When the patient comes out of the acute care setting and moves to a post-acute setting, we should be able to talk to each other. And right now, Latin is speaking to Greek, is speaking to French, and we don't know what each other is saying. We have to improve discharge planning. We can't make a coordinated plan that has a higher chance of success if we don't speak the same language. And we need to be able to use that data to do research so that we can improve our practice as we go. Why is there so much attention on post-acute care settings all of a sudden? Anytime the money goes up, when the bills go up, it draws attention. The post-acute care setting has an rapidly escalating price tag. We know that the data does not speak across the continuum. The goal is to ultimately establish payment rates according to the individual characteristics of the patient and the needs of their plan of care in their care setting. If we do that appropriately, we can bring the cost down. What does standardization mean? This is not a negative word. We're looking at these 4 settings. Looks rather like a slot machine, doesn't it? Only we're not winning. The coins are not coming out for us. And that's because we are not speaking the same language. When we all use the same terminology across all 4 settings, son of a gun, we've got 4 cherries in the slot machine, and the patient wins. That's the goal, is that the patient should be winning. What we are hoping to produce with the changes that are being made is to have standardized patient assessment data elements. These are called SPADES. These are question and response options that are identical for all 4 PACS set instruments, assessment instruments, that will give us output of standardized data, so that now we can look at the same measure across all of the potential post-acute settings. Our data will talk to each other, and the one who benefits will be our patients. To get a good summary of the IMPACT Act and the goals and the process, you can go to this link on the CMS channel on YouTube, and you can listen to this video, and it will give you a great deal of information. Oasis D will be effective January 1st of 2019. Sounds like it should be so far away, but yesterday on my way down here, I heard that it's like 50 days until Christmas. I don't need to hear this. I have not done any shopping. I don't want to talk about it. Who's with me there, right? I'm sick of the Christmas carols, and it's only been 2 days. The Oasis changes fall into 3 groups. On your left, you have 6 new items. We will be going over those in detail, and I would urge you, when my partner in crime, Charlotte, comes up here to talk about J and GG, you really need to focus on these, because these are critical. 7 items have been revised. You're going to need to look at the wording changes and understand what these changes are. 28 items were removed, and I will briefly talk about why. Now here's the really big list. 33 items have had changes made in the guidance manual. What matters about this is we all use the guidance manual in order to look at how we teach our staff to answer the questions and how to do the assessment properly. So you're going to need, between now and January 1st, when you're preparing to train your staff, you really need to look at these guidance manual changes. Just changing a word, adding one, taking one out, changing the tense is a critical difference. So please go through these manual changes carefully. In the first presentation, there was a brief mention of standardization, cross-setting alignment, and evaluation. These are the reasons why the Oasis is being changed. The IMPACT Act wants us all to talk the same language, so that, remember, our patient can get 4 cherries and win. In order for that to happen, we need to align the measures that we're collecting quality data on across all those settings. That requires us to carefully evaluate the measures, the wording, and the process. And we've just now started to get more comfortable with the changes in survey and certification, right? We had all those regulatory changes. As we go through these questions and go through the Oasis D, what you're going to see is that much of this is bringing the Oasis assessment closer to our certification requirements. And as we go through, I want you to look closely at the one clinician and how we do our assessments and how we talk to each other. And just like in any other setting, updates and corrections to our manual have to be done on a regular basis. We're all human. Changing the tense of a word sometimes slips through the cracks, and we have to go back, check each other's work, and make sure that everything is right. I mentioned the 2 new items. On your screen you have Section J, Health Conditions Falls. There are 2 queries here. Charlotte will be going over them in depth. but you really are going to need to pay close attention to the wording. And in section GG, we're going to look at assessing functional abilities and goals. We're looking at prior functioning in everyday activities. How did your patient do? At what level could they function independently in getting through their ADLs? We're going to look at prior device use. Did they, like I do, use a cane? Did they use a walker? Do they need a lift of some type? We need to know, before today's assessment, what did they need to get through every day? What could they do for self-care? How mobile were they? And we're doing this in a context that means each setting is using the same query and identifying the same responses. So here are the new items and the list of what time points we do these. When do we collect this data? And is the wording identical at every time point? Remember earlier I said there were 7 items that were revised? Here's the list. And so as we look at this in more detail, you're going to want to pay attention to what changes were made. The Oasis queries have been revised in terms of wording. Perhaps an additional response was added, but you're going to need to look carefully at this. In 2017, CMS undertook a comprehensive review of our Oasis assessment tool. The purpose was to see what could be removed to reduce the data collection burden. Over the past almost 20 years now, we've all gotten kind of used to the Oasis, but do you remember when Oasis first came out? And we looked at this and we said, oh my God, there's over 100 questions. Oh my God, I can't possibly do this. But we learned, didn't we? And EMRs came along and they did some of the work for us. But CMS is still concerned about the number of questions, and so as a result, they've removed 28 items to reduce your burden. Thank you. Why were they removed? The ones that were taken out do not support the quality reporting program measures. They don't support PPS to determine your payment. They don't coordinate with the current survey and certification process. They don't support the value-based purchasing measures. They are not a critical risk adjustment factor, and they don't match with the COPs. And as we all know, the COPs trump everything. The items that were removed are on this list, and on these slides you're going to see at what time points and when they were collected, and now they're being removed. And that goes for these slides here, okay? I'm not going to go through them in detail. That's the sort of thing that you can do yourselves, and that you want to use these slides in training with your staff. These items, and there are 4, were removed from the discharge time point only. So again, these slides are critical for your use in training your own staff when you go back. These 2 items had long lists of options for your responses, and what has happened here is that select item responses have been removed. Now, I know that the types and sources of assistance and the reasons for emergent care, in both cases, the responses that are in Oasis C2, many of us have been using these to collect data that we felt was very important for use in planning care. Looking at, why is my patient going to the emergency room? I need this information. How am I going to focus my improvement plan if I don't know why they went? Because so many of these are being removed, you're going to need to find another way to collect this data. Whether it's you keep it built into your electronic record, whether it's a process you put in place, if you need that data, you're going to need to be able to collect it in some other fashion. Your skip pattern changes have also been affected by the items that were removed. Let's take a look at the revised items. We're going to look at which ones were revised and talk a little bit about the changes. The revisions involve either a change to the assessment item and its related guidance, or, remember that really long list? Those are the ones that the revisions were made in the guidance manual only. This is, again, the same list from our previous slide with the 7 revised assessment items where something in the query or its responses were changed. You'll find these in different time point versions. The change might be in the item text, in your response options, whether or not you can still use the dash, which we're all just now getting used to, right? And the skip patterns. Because remember, if you removed items, that's going to affect the skip patterns as well. There's that list again. Every time I look at it, it looks longer. But you really do need to pull out your manual and go through and check them off as you read them in the manual and look for the changes. Changes have been made for those items in the intent, in when the item was collected, the response-specific instructions, the types of examples that they've given you in the manual to help you understand, and the data sources and resources. We've also looked at adjusting the guidance so that you would understand how we've expanded the one clinician rule. And that's a very important change. And as we go through it, you'll understand how this aligns more closely with the new requirements for the conditions of participation. Content for some of the items has been removed, skip language changed. As I said, we aligned with the new COPs. And that's critically important because these documents need to talk to each other. And we are, again, aligning language across the settings. In the manual, references to specific the Centers for Disease Control, things have been replaced with more generic statements, added definitions. We took out all the references to process measures that we don't report on anymore and made some minor editorial changes. Okay, now it's time to check and see if I put you all to sleep yet. Our first knowledge check is, revisions to Oasis D involve which of the following? Changes to the assessment items, revisions to the Oasis D guidance manual, or both A and B. Use your phones or your laptops. Look at that. I think everybody's awake. I must be talking too loud. Let's see if you're right. And look at that, A and B together. Very good. Okay, so as I said before, the revisions to Oasis D do include both specific changes to the 7 assessment items and their guidance, as well as that lengthy list of revisions to the guidance manual itself. Those 7 items, notice that this list keeps reappearing because it's very important. We want to be sure that you draw your attention to this. These are the ones that have been revised. Do you remember 1028? Seems to me I spent a lot of time standing up here talking about height and weight and the diagnoses and so on. 1028, this is a standardized assessment item from C2, but we have revised the response options. That's because in 1028, we had the 2 diagnoses to check off. In C2, there isn't anything else. It's either check off the PVD or the diabetes. And at the time, all of you that were there were going, wait, how am I going to know? If there's no check mark, they either don't have any or the nurse skipped it. It could be either or. And we had to say to you, well, that's your quality check. Now we've given you the third option to say, no, none of the above. So now you know if there's no check mark, somebody was sleeping. In 1306, unhealed pressure ulcer or injury at stage 2 or higher, we have incorporated National Pressure Ulcer Advisory Panel terminology. I think these groups need shorter names, so that it aligns with the other post-acute care instruments. The text was revised so that now it says, excludes healed stage 2 pressure ulcers, and now it includes the word ulcers injuries, okay? And that's an important difference. Anne is going to talk about that in more detail later on. Here's what the item looks like, and you can see that as of January, it will have the word injury in there. And again, in M1311, the current number of unhealed pressure ulcers injuries at each stage. Here, the item was retained, but now it is different between sock rock, follow-up, and discharge. So if you were to take M1311 from a sock rock tool to a follow-up to a discharge and lay them across your desk, you would find they're not the same anymore. So you want to take a very close look at this. This was done to align this query with the other post-acute care instruments. A dash is a valid response for the discharge time point only. CMS does expect that the use of the dash will continue to be a very rare occurrence, but again, this was done to standardize the measure as we went across all settings. In M1311, again, the text was revised. The ulcers and injuries the wording was added, the word device was added, because not everything that's used to treat an ulcer or an injury is a dressing. Sometimes it's a device. Otherwise, how else would you address some of the tools that we use in wound care now? This is what the question looks like on the tool, with the changes themselves highlighted for you in yellow. And here, 1311, again, the changes are highlighted in the discharge version, so that you can see there are quite a number of changes there. In 1322, current number of stage 1 pressure injuries, what you will see here is that it was retained at sock rock and follow-up, but it has been removed from the discharge time point because it was simply not needed for measure calculation, so they removed it to reduce the burden on you and your staff of collecting this element. This aligns it now with the other post-acute care settings by replacing ulcers with injuries and updating the definition. Here you see how it's been changed. In 1324, we have updated the terminology and added the word injury again. Here on the slide, you'll see what the question looks like with the changes made. 2102 has different versions of this item for sock rock and for discharge, so that, as I mentioned to you before, they are no longer going to be the same all the way across. Several items have different wording at different time points, and this is one of them. And here as well, some of the response options were considered not essential for measure collection, and therefore they've been removed to make it easier for you. However, with this question, as with the emergent care question, if you're using this data for other purposes, then you will need to find an alternative method to get this information so that you can track it, okay? In types and sources of assistance, the only option that was retained is the supervision and safety. Okay, and there you can see the difference. This is the discharge one. You're going to want to take these and put them side by side so that you'll be able to have a better picture of what changes were actually made. This is the tool as it appears when you're using the actual Oasis. Oh, one too far. The reason for emergent care. I know I've had several people talk to me about how this is an issue. They're concerned about this because they've used this data for a number of things. But the reasons for emergent care, this data is collected on transfer and discharge. The response options that were needed to calculate a potentially avoidable event were retained, but 15 of the 19 have been removed. So you're going to really need to look at that list and figure out if you need those other 15 data elements and which ones of those are meaningful enough for you to find an alternative method to get the information. These are the 4 options that were retained: improper medication administration, hypoglycemia, diabetes out of control, other, and unknown. I have to have an editorial comment here. I work with providers doing quality management. If your staff is using reason unknown, somebody's being lazy. You need to know why. You cannot reduce emergent care if you don't know why. And unknown is not an acceptable why. This is what it will look like on your screen when you're answering the Oasis question. So let's see if I've lost you. I know that we're very tight on time, and so I am going through this very quickly, but I would like to at least see how we're doing on the knowledge check. Which statement regarding 1028 active diagnosis is true? New time point versions have been created. Response options have been revised to include none of the above. And the dash is not a valid response. Look at that. Oh, I think we have a consensus. Let's see. And there you go. The response options have been revised to include none of the above, to address the issue that we spoke of before. So that now you'll have this new response option of none of the above, and you'll know that your clinician has done the assessment properly. Let's do one more. The same assessment version of M1311, current number of unhealed pressure ulcers injuries at each stage. The same assessment version is used for sock rock, follow-up, and discharge. True or false? What do you think? Do you remember? Oh, look at that. I was going to say for a second there, I thought we had 100% agreement. Oh, people are changing their minds. Oh, let's answer the question quick. And the answer is false. Remember, in several questions, wording has changed from different time points, so that different versions were being created for sock rock, follow-up, and discharge. One more. What is the best response for 2102, types and sources of assistance? Need more coffee. Response options have been removed to reduce your burden. New time point versions are created for, my goodness, look at that. I didn't even finish reading it. Oh, we're changing our mind. And we're changing our minds again. My goodness. Okay, group, let's decide. A, B, C, or D. We have a majority. Let's look quick before they change their minds again. And the answer is all of the above. We were kind of 2/3, 1/3 there, so let's remember, it is all of these reasons. The options that were removed were to reduce the burden on you and your staff. New versions were created for sock rock and discharge, and the lettering sequence was retained for the remaining reviews. I mentioned the one clinician convention. When you have a nurse opening the chart, doing the initial assessment, and therapies are required, the one clinician convention made it difficult because we want the therapist to be part of the plan of care. We need everyone coordinating together. So as of January 1st, 2018, this year, this was modified to say that while the assessing primary clinician is the one responsible, still and forever, for accurately completing and signing the comprehensive assessment, he or she may collaborate to collect data for all the Oasis items if your policy allows. We talked earlier about aligning the Oasis elements to the COPs with the requirement for interdisciplinary coordination and communication at not just Oasis time points, but across the board. That's where this matches up to. Expanding the one clinician convention means that now you get all the disciplines to talk to each other, they communicate, coordinate, and then that responsible clinician synthesizes that into the coordinated complete assessment. And this is actually assisting us to better align not only with our own new COPs, but also with how things are done in other post-acute care settings. There is a link here so that you can go and read the actual wording for this particular change, and it does give you some excellent information. There are no changes to the drug regimen review item itself. The guidance was refined in order to promote cross-setting alignment. Drug regimen review was first introduced to us in 2010 and then revised in 2017. But these elements are now being implemented in the other post-acute care settings. That will make this uniformly applied across all the different settings on these starting dates, so that now we'll all actually use the same language. 1060, height and weight. This is a reminder that we need to do this at start and resumption, and we need to reinforce how we do this assessment. We are measuring it in accordance with your policies, and you should have a policy and/or procedure. We use mathematical rounding. This is a height and a weight that is measured by agency staff. It's right there. It needs to be directly measured by agency staff. You cannot use a weight that is reported, self-reported, or derived from documentation from another setting. It should be obtained by agency staff as part of the SOC ROC. If you have a previously obtained by agency staff height weight, you can use that. But you, in the previous 30 days, but you cannot use information from the family, from the spouse, from the patient, or from another document. So let's look at the knowledge check here on the One Clinician Convention. The comprehensive assessment, which includes Oasis, remains the responsibility of one clinician, or the assessing clinician can use feedback from other agency staff to complete the question, or both A and B. Which one of those is correct? Oh, very good. Don't change your minds now. That was a hint. So the correct answer here doesn't want to, are we done? There we go. The correct answer is both A and B. And as we've already said, the primary clinician is responsible for completing and signing the assessment, but is now allowed to collaborate with her peers. What is the best answer to this one on M1060? We have to enter a weight that has been reported by the spouse. We can use a documented weight from the nursing home summary. Use a documented agency of, look at that. See, you caught me, you were all ready. Very good. Okay. Come on. Doesn't want to let me go. There we are. And the correct answer is that you can use a documented agency obtained weight within the previous 30 days. So Oasis D is going to need to be implemented with all of its changes on January 1st, 2019. The changes include new elements, revised elements, elements that are different from time point to time point, the one clinician convention, removed items so that we have a reduction in your burden, and changes, edits, and corrections in the manual itself. You want to think about how you're going to train your staff in order to put this into action. So think about your action plan and share your ideas with one another. And that brings us to our questions. And here comes my next partner in crime.